and options by which we can remove the cataract. So first of all, regarding the gross anatomy and then the histology. Regarding the gross anatomy, it is a biconvex layer, biconvex lens, okay, and it is almost 10 millimeter in length and 4 millimeter 4 millimeter in from anterior to posterior, and lens consists of three parts. The outermost part is the, which you can see, is the capsule. This is the cornea, so this is the anterior part, this is the retina, so this is the posterior part. This is called the anterior capsule, this is called the posterior capsule. Are you getting my points? In between them is lens fibers which are being produced since the uh, embryo was formed, and it is called the nucleus of the lens. With the passage of the time, its size increases till the age of 70. It becomes so large, and by the year around about 60, 70, it becomes opaque or white, and that is what we call cataract. And in between the nucleus and the capsule is a semi-transparent, you can say, uh, not semi-transparent, totally transparent, semi-liquid layer. These are three layers. Okay, nucleus, capsule, and cortex. Third one is the between the two is the cortex, and the lens as a whole is made up of proteins. 98% of the lens is made up of proteins, and 2% is in the water. The function of the lens is to converge the light. The total dioptric power of the eye is 60 diopter, 58.6. 58.6. For understanding, we divide it in, we say, let's say it's 60 diopters. So when the rays of light come, the first interaction of the rays of light is with the cornea, and cornea contributes towards 43 diopter spherical to the convergence of the light. Now 60 minus 43 is 17. It means that the remaining 17 diopters almost is contributed by the lens, and so the ray of light, this convergence, this second convergence, and here on the macula. Similarly, this lens converges, and this one convergence is at the, it should have been like this. It is more, and then a little lower from the lens. So cornea and the lens converge the light on the macula lutea. Understood? This is the basically anatomy of the eye. Histologically, lens is made up of collagen proteins and water. Uh, Physiologically, you can compare the lens with a red blood cell. That is, it contains sodium potassium pump, okay, which constantly pumps the, because the lens is present at a place where anteriorly is the aqueous humor, water can come into the lens, or posteriorly is the vitreous humor. If vitreous is liquefied, sometimes water can come from the vitreous humor. So to make it transparent, the sodium potassium pump continuously uh, throws the water away from the inside the eye. Similarly, it as you must have read the glycolysis and glucose pathway. It uh, it it has the same pathway for the degradation of glucose, and if the oxygen is not sufficient, then in the body, if the oxygen is not sufficient for glucose glycolysis pathway, which byproduct is formed? Lactic acid and
alcohol.
yes, and that alcohol is called sorbitol.
G.
And here, when if the enough oxygen is not present, then sorbitol is formed, and sorbitol accumulates, and it is also a contributing factor towards the formation of cataract. In the cases of diabetes, in diabetic cataracts, this could be a proposed mechanism of premature cataract, presenile cataract, which occurs before the age of 60 or 70. Usually, the cataract, which is called Sfed Motia in Urdu, develops with aging, usually after 60 years of age, and it is because of senile sclerosing and degradation of the proteins, and this is called cataract. If all the three layers of the lens are opacified, we call it mature cataract. If all the layers of the lens are not opacified, for example, nucleus is cleared and posterior capsule is involved, we will call it immature cataract. This is all about, or not all about, the important facts about the anatomy and physiology of the lens. So, you will continue. Can you pause it? Pause. Not. As we have seen the anatomy and physiology of the eye, lens is transparent. There are three structures in the eye which are transparent. One is cornea, second is the lens, third is the vitreous fingers. If blood vessel is present in any of these three, it is pathology. And in eye, cataract is the most common cause of reversible blindness worldwide, all over the world. So now we will try to see see compactly what are the different options for the treatment of cataract. First of all, there are no eye drops which can reverse the cataract. Cataract is defined as opacification of the crystalline lens. There is no way of reversing the procedure. No eye drops or medicine can reverse it. Number one. There is no medical treatment. Number two. The treatment is always surgical. You have to take it out. What are the different techniques? Number one, ICCE. It is called intracapsular cataract extraction. Intra. It is now obsolete almost. Done only in very special condition. Intracapsular. Then we have the ECCE. Extracapsular cataract extraction. This is now the procedure of choice. It has two parts. One is conventional, in which we have been doing for years, where we give the incision of 8 to 10 millimeters and apply almost 3 to 5 sutures. And second is the refined form of conventional extracapsular cataract extraction, which is called phacoemulsification. in which we give a very small incision, 2.8 to 3.2 millimeter, and with that small incision we remove the cataract with a special technique we will be discussing shortly, and no suture is applied. And the difference between intra and extra is that if this is the lens, and in intracapsular cataract extraction, when it was performed routinely, all the lens was removed. What is the difference between intra and extra? We leave the posterior capsule in extra capsule cataract exception and phaco. It must be intact. If during surgery nowadays, if the posterior capsule is ruptured, it is a nightmare for a night surgeon, because this is a posterior capsule where we place the lens. Intracapsular cataract extraction was performed when the lens was not invented. Now we put intraocular lens, and that lens is placed on the posterior capsule. So during the surgery, all the care the eye surgeon uh, gives uh, is to save this very thin structure, which is very fragile and can easily rupture. Then there are many complications. Then you will have to go for other uh, modalities which are not that uh, good and paying in the short and the long term. Anyways, just a thing. Now let's discuss these two procedures. In extracapsular cataract extraction, this is the limbus, that is junction of the cornea and sclera, and we have dilated the pupil with midrasil. This is a picture. This is the view from the microscope, and this is 12 o'clock. The surgeon is sitting here, like here. Okay, I'm looking from upward from the microscope. This is 12 o'clock. What we do in extracapsular cataract extraction, we give incision 8 to 10 millimeters at the limbus. Okay. After this, we make a small opening, and this is the anterior capsule of the lens. You see, this is the sagittal section. You, with the insulin needle, you curve it, make it a knife, and you start giving incisions like this. And it is called cane opener capsulotomy. And then you remove it. It will give you a picture like this if you see it. Anterior capsule is removed, and here after that, with the corneal scissors, you complete this incision to full thickness incision. Now you can see that the lips of the posterior and anterior lips will be they can be opened. Then with the help of two instruments, you put the gel into the eye, you put some blunt instrument like squint hook here at the posterior part of the eye or on the sclera, and some other like suture time at the 12 o'clock, and by alternate pressure you uh, remove the nucleus, this part, slowly from the eye, and here is the nucleus, the cataractus lens. Okay, it will come out of this wound. Understood? Understood? When we will cut it and we have removed the anterior capsule, we will give the pressure, it will come out of the anterior capsule through the lips of the cornea and sclera outwards. Understood? Then what are we left now? Nucleus is removed. We have just now the cortex and the posterior capsule. Now, what we will do? By this incision, we have a cannula, two-way cannula, which one part is irrigating, that is normal saline or ringer, and the other part has the syringe which sucks. With the help of that cannula, this cortex which is left behind, we remove it very carefully, not to touch the posterior capsule. If, for example, this capsule, this is ruptured posterior capsule, then it is so fragile that it starts on increasing itself, and the vitreous humor which is present behind this, it starts coming into the anterior capsule. This is what we no eye surgeon wants. So we have to save the posterior capsule and remove the cortex. After removing the cortex, we are left with this. So what we will be having? We will be having this. Now this is pupil, and this white transparent layer which is not visible is posterior capsule. Then we will put the gel methyl cellulose to make the anterior chamber, and this is the artificial lens. Okay, we will put this artificial lens into the eye, right? We will put the myocol or carbacol, which is parasympathomimetic like polycarbonate drops. Pupil will constrict and the lens is at its place. Now we will apply 5 sutures. First at the 12 o'clock between the cornea and sclera, then here, third one is here, fourth here, and 5 here. That is it. The cataract surgery is complete. After then we will pad the eye. The next day we will open the eye. Patient may see 6/18 or so. Then after 40 days we will remove the 5 sutures, because any suture might be loose, any suture can be tight. They may produce astigmatism, and this is the thing. The two things led to the invention of phacoemulsification. One thing, that besides the wonderful surgery, patient's vision is not that improved, because astigmatism is so high, because this suture is, for example, so tight. There will be this median will be flat, so it will give a lot of refractive error. Then you have to remove it, but you can't remove it before 40 days before the wound is fully healed. And the second thing which led to the invention of leukomulsification is the this large incision, which takes time to heal and which can be a source of infection. So now we will learn how this extracapsular cataract extraction took the form of now the surgery, which is the drug of procedure of choice. This is the limbus. This is the dilated pupil, right? This is the 12 o'clock position, for example. This is supratemporal position. We will give incision at the limbus of 3.2 millimeter with special keratome. I need your attention. Okay. After giving the incision, here we will with the special insulin needle, we make curve it and make a knife, and we will not do cane opener capsulotomy. We will do CCC, continuous curvilinear capsulorhexis. That is this is the anterior capsule. We will remove it, but in not that manner. We will remove it like this. We will, after putting the gel, uh, we will for remove it like this. It will give the same view, but you see, this is the capsule, and this is the anterior capsule removed. It needs a lot of practice. Now, what we are left with? We are left with the nucleus. Now, what will we do? The next step, the incision. Through that, this incision, we will inject water between the this is correct. We will inject the water between the posterior capsule and nucleus, so that it is called hydrodissection. Dissection by water. It will remove the adhesions between the cortex and the nucleus and the posterior capsule. Are you getting my points? So, by doing this, and the nucleus will become mobile. So, this is the nucleus which is now mobile. Okay. This is the nucleus. That is, let me draw like this. Now we will enter the phaco probe, which is like a pen, and we have a control in our foot. We will, after putting the gel, we will put this probe into the over the nucleus, and we will push the foot pedal, and it will phacoemulsification works on the procedure of ultrasonography, ultrasonic cutting. It ultrasonically cuts the nucleus inside the eye. The main difference between the extracapsular and this is that the nucleus is emulsified and eaten away inside the eye, and it will make a groove. This pen will move like this. Then we will do it a couple of times till we see the frontal globe. Then we will rotate the nucleus and we will make the second groove here. Getting my point?
Yes, sir.
Now you will break, you will, with the help of one instrument like dialer and some other instrument, after injecting the viscoelastic so that the eye is formed, you will convert this nucleus into four parts, four quadrants. One this, second, third, and fourth. Now you will in the phaco machine go to the lower power, which is called memory 2. That is, the power of the phaco is now decreased, and now you will one by one eat away all these four structures, all these four parts of the nucleus. When you will eat away all these four parts, what you will be left with? You will be left with cortex. Now take out the phaco probe, and with the same two-way cannula, you will enter and remove this remaining cortex. After this, you will have an intraocular lens which is injectable or foldable. It will be folded like normal lens diameter is 5.5 to 6.5 or 6 millimeter. So for that we had a needed large incision, but it is a very small incision. So we need a small lens, small uh, lens, but how can we put at least 5.5 millimeter of lens into the eye? So we use a foldable lens. The lens folds like this. It is inserted into an injector like the syringe. Sometimes it is preloaded, sometimes we load it ourselves, and we load it here and it goes inside the eye, and it is like this. It looks like this lens. It will go this lens through this small incision. You will inject the lens and it will open up it will go into the eye. Are you getting my point?
Yes, sir.
It will open up into the eye, and so here we have the whole lens. There will be no demarcation line. This is just for your understanding. And same haptic, and this is optic. And now you can see to just 3.2 millimeter we have inserted 5.5 millimeter of lens, and there is no need of applying any suture. And that is you will, with the help of the two-way cannula, you will remove the debris and you will pad, and on the next day the patient should be able to see, after good phacosurgery, he should be able to see the last lines in basics. And no astigmatism because no suture, early convalescence because the incision is very small, and this is all about the basics of phacoemulsification. Thank you very much.